with that, I think we can move on to the third talk.
Yeah, the third talk is by Dr. Partha, who has been consultant diabetologist and at Posthumous Hospital Emeritus since 2008. One of the main areas of passion in helping redesign diabetes care in an attempt to integrate disease management across the primary and secondary care. He is also co-creator of a TED Talk, talking about not TED Talk, but TED Talk in type 1 diabetes, rise of the march, and type 1 diabetes comic origin. He holds the role of Associate National Clinical Director, Diabetes at NHS, England. Recently, he has also been involved in CGM being made available to all type 1 diabetes pregnant patients, good news, as well as a uniform access of Freestyle Libre and updating of driving guidelines in relation to use of technology in those living with diabetes. He's also regular biographer of BMJ, and he'll be talking about the language in patient interaction. Very interesting topic. So over to you, Dr. Parthakar, on this very, very new and very, very innovative subject of the language in interaction. Over to Dr. Parth.
Thank you. Can you guys hear me? Okay.
Yeah,
Yeah.
there's a question before that, I think.
Okay, go for it.
Answer the question before you begin your talk.
Mm-hmm.
Value of language in patient interaction, does it matter? Yes, no, maybe. Please answer the question. Please answer this question and we can move ahead. Okay, I think should we wait for the answer? I think Partha, you can start sharing. Yeah, there is. Yeah, it does matter. The
Okay.
job is very easy. I think
Yeah, very easy.
lecture is
Excellent.
almost over. We don't need to give lecture. So in any
Excellent.
case, you continue
Okay.
to talk on language. Yeah.
Thank you. Thank you very much. Hope you can all hear me. So I'm going to start by just saying a few thank yous to begin with. Most importantly, of course, to Bunchy and his team for the invite and everything. And that's been repeated a number of times. So yesterday I did a talk as well. So thank you very much for the invite. Very much appreciated. And obviously to all the organizing team who have helped out. I also wanted to mention big congratulations to Dr. Chawla, who I know is the chair, about her new appointment in Juhu. Is that right? And also a lot of jealousy to say that you're that close to Amitabh Bachchan's house. So those are the two things I had to mention to begin with.
Oh,
But many congratulations on that.
Thank you, Partha. It's nice to see you here. We meet every day on Facebook, but this is even better.
Indeed.
it's okay.
Right. So I will share my screen. Give me 2 seconds. Should come up okay, hopefully. If all works well, technology. Uh, right. That should do it. Yep. We're good.
Yes,
Is
sir.
that okay?
Perfect.
Yeah.
Perfect.
All right. So I'll go through the talk. So as mentioned, so my name is Partha. I'm a consultant. I work in the UK. And one of the things that we have been looking at is language. And why is it important? Just a very brief overview. And then also to just mention as to how things are looking at from an Indian perspective, because we have had some great collaboration with Indian colleagues about this particular issue. So first of all, this number, so I always, whenever I do a talk in public, I always ask people whether they know what this number stands for. And we always have jokes about whether it's my PIN number for my bank card or whatever. But 8,760, very simply put, is the number of hours in a year. And the reason I put that up is because then if you triangulate that to how much time we as doctors in our busy lives are able to see anybody, whether you're a doctor, dietitian, psychologist, nurse specialist, even with the best will in the world, simply because there's so many people out there to see, you'll only see them 2, 3, 4 times, however much times you see. In a UK setting, we put it there and we said, let's say with really good input, you see them 4 times a year, you spend half an hour per each visit. That's 2 hours in total, right? And that constitutes 0.02% of the patient's life. And I think that's a very important concept, which we all need to sort of not forget, that in a long-term condition, it's very difficult to make all the changes we want to make in 0.02% of that person's life. It may be feasible, let's say, for example, if you're a pituitary surgeon, and some of us do endocrinology work. So the question then becomes, in an endocrine setting, can we do that? Probably we can if you're a pituitary surgeon, but sometimes it's not possible. So going forward, the reason for that is if you look at this data set that is around all the countries, if you look at it all across Europe, and I'm pretty sure it's probably the same in India, and apart from a few countries, we are very good at measuring things. We're just not very good at getting people to as a population to a target. Many reasons for it, as mentioned by my previous speaker as well, the issues about diet and trying to reverse things, the socioeconomic situations, etc. But that's the reality of where we are. But here comes the things is that when we see a patient and when we see them, our main things become whose target is it? And is it our target when they come and say, is it about blood sugars? How much is the person worried about it? We've all been in that conversations whereby are we dodging the conversation? For the person, is the most important thing their weight? Is the most important thing their diabetes? What is it? And it gets sort of in a very tight and a small consultation time, it becomes very tough to get anywhere. I always give these examples of where we are. And there is always still the hierarchy system that we work in. As a doctor, we are where we are, or a healthcare physician, or a specialist, and then patients come and see us. This is the modern world. And I give an example. This is beyond diabetes. This is slightly even outdated, as you can see. But the point is that a majority of people in this world are using technology means. Now, why do I talk about that? Have a look at this. This is about social media use in the world. And I'm pretty sure all of us in some format use it, whether it's Facebook or Twitter or, WhatsApp or, the modern world, we're talking about TikTok and all that. People are using it. Our patients are using it on a regular basis. Okay. So in the middle of this, what we do have is this. So just a very simple example of what's going on in the world of social media. So this is a very good, there's even an updated version of this. And you can see the issues with people differing between type 1 and type 2 diabetes. Top of the list for type 2 diabetes is diet. And as the last speaker so eloquently put, one of the conversations that is going on all the time in people's mind is, well, what diet is the right diet? And then you're going and seeing a physician, and we are all trying to sort of move away around. So people are talking about this all the time. These may be their priorities, which we may or may not focus on. You can see with type 1 diabetes how big anxiety is. How much do we address that? How much do we say, well, actually, in that 0.02%, I'm going to try and change your type 1 diabetes or your type 2 diabetes. Very difficult to do. So let me give you an example, which is quite relevant in the UK, but I'm sure it's the same in India. We always say, so what is the best diet in the world? So we have this debate all the time. Is it low calorie? Is it low carb? Is it, this, that, everything? I always say the best diet in the world, apart from your tolerability and sustainability, because that's got to be the two big things. There's no point in going on a diet if you can't sustain it. But one of the biggest things in the world, which we sometimes forget, is the affordability. So in a UK setting, it's very easy for me to turn around and say, you know what you should have for breakfast? You should have avocado in the morning and you should have some bacon on top of it. That is fantastic. But for a major section of the population, it is just not going to be possible, right? When you're struggling to put food on the table for your children, which also happens in the UK, it is not a debate that is there in the person's mind. We as a professional can feel it might make an impact. For the person, it won't. And I think that's quite important to bear that in mind. I don't know how many of you have heard this particular word, which is used, and it's used by a lot of us when we get to senior positions. The common Hindi parlance for that is "jab mere samay mein, main jab chota tha." So you hear about "in my time." In my time is a very common concept that is used all the time by a lot of people. We always think that when a few years back, when I was younger, things were much better. In psychology, it's called rosy retrospection. We all believe. For example, for me, the movies from the 70s and 80s were the best. There was nobody better than Amitabh Bachchan. It's not possible. You talk to a modern generation, they will go like, I don't know what you're talking about. We have far better films. So everybody looks at their generation when they're growing up as one of the best. But if you look through time, I put this slide up because this is the presumptions we make, for example, about teenagers. Those of us who have got teenagers at home or young adults, the concept is that teenagers don't listen to anything. Teenagers are just, you know what they are. They don't listen to anything. They smoke and they drink and they don't listen to their parents. They're just unruly people. On the other hand, if you look at evidence base, you'll find out that here is one. Teen births have been plummeted. More responsible teens as you've gone along. But I would ask you to have a look at this particular slide, and you can have these slides. Very well referenced things done over the years. You can see from 1991 onwards, things like regularly wearing seat belts, trying a cigarette, marijuana, physical fight. Teenagers of nowadays or young people of nowadays are actually better behaved than what we were, which is a fundamental change in how we believe when we look at young people. We look at our own friends and we say, or our own children, and we say, Use kuch nahi hoga, or they won't do anything, or he has to grow up. What we forget is how people are maturing over things, how times have changed. So not to go out into any consultation with presumed versions or presumptions made about people. Here's an example of what we tend to use in clinic, which has really helped us. And I'll give you the background to this is we try in our clinics and say to people, when there's no point in getting people to a type 1 diabetes clinic. This is for the young people. This is from 18 to 25 who are always being seen to be as inverted commas difficult. But what we changed the approach to say, why do you want to come around and talk to us? What do you want to talk about? We eventually got to their diabetes. It took our time, but at the moment we are very proud of our overall HbA1c number, and we have the lowest what we call non-attendance rates. So one of the problems with the public sector funded thing, because it's seen as free, a lot of people don't come to clinics, especially in the teenage groups. But what we have been able to change, because we're having conversations which are different, not just about their HbA1c every single time. That's helped us a lot. And as a center, we have got one of the best HbA1c across the board because of that. And that's what we're very proud of as we go along as well. So I won't play this game, obviously, online, but just to make a point is that if you look at those 5 things, right, these are some things which we should or should not be doing, okay, which we advise our patients to do. 30 minutes moderate exercise 5 times per week, 5 fruits and vegetables per day, religiously taking all your tablets, never missing an appointment. And of course, safety wise, you should not be texting and doing that when you're driving. Now, these are simple advice. Forget about diabetes. This is simple advice which we should be following ourselves because this is important. It's good for health. It's nothing controversial in here. But if you reflect and think about it, of those 5, I don't know about you gentlemen and ladies who are on this call. I don't know. I probably would struggle to do more than 2. And that's not because we don't know the advice, it's because life comes in the way. And that's what we see all the time. So I think the point we make is that if you've got somebody who's got with diabetes, it's very easy to say you're not listening to my advice when we struggle ourselves to follow our own advice. And that's the sort of one of the fundamentals of it. The concept of language matters. We first of all, there is this position statement which came from Diabetes Australia and then followed up the American Diabetes Association, then did something along the same lines. And there was this paper which came out called the use of language in diabetes care and education. So in the UK, we said, all right, why don't we progress? And this was about 2 years back and see what we can do. So we got a lot of patient groups together and we did some research, which I think is quite important because we went out and spoke to a lot of people around with diabetes type 1 and type 2. And I'm not going to read these out to you, but as you can see from the slide deck, one of the big and important things there is the whole point is life gets in the way. And I go back again to the concept of 0.02% of the patient's life or time is with you as doctors and physicians and healthcare specialists. The rest of the time, life gets in the way. They don't live the life that we do. We may, touch wood, or hopefully come from a better position of wealth and literacy, etc., that not many patients of ours will be fortunate enough. Some are, but not everybody is. Same thing again, talks about, and these are sort of things, that paper which is out there. So this is something that they said that they had picked up from their doctors in casual conversations while they've gone to a supermarket and seen their doctor talking about, or their doctor coming to and say, what's your diabetes control? Should you be eating that? That's a very common thing used. And it's probably one of those non-compliant type 2 diabetes. These were some of the things that were said that they felt that. So one of the very good examples I have is that they went to a party, this particular patient, and saw 3 of the doctors there, absolutely fantastically enjoying their food and having exactly the type of food they spent all their time advising the patient they should have in moderation, which all of us do to a certain extent. I mean, I love my jalebis and all that. But the point is that patient standing there going like, hang on a second, you told me off. You didn't even have a conversation in a much more normal way. You just told me off for having those jalebis. And that's not right. So I think it's difficult. So I think the approach is not to say that, oh, we shouldn't tell people what we should, but I think we should be more appreciative of the language we're using and the way we are saying that, because we ourselves are not completely immune or, in the sense of not completely guilt-free from that respect. So there is a document out there called Language Matters. which was done by the NHS, which came out, and simple things. I'm not going to spend time on it. It's there, but I'll come back to a few things about it. But I think there were some tips that were saying about what we should do. Don't shame people, don't threaten people. And I like the last one, because there's been a lot of controversy about this recently in India about a statement done by the BMJ editor, Fiona Godley, that, insulin, people are deliberately putting people on insulin, which costs a lot. Well, I think a lot of conversations go along the lines, if you don't improve your control, you'll end up on insulin. So if you're going to threaten people with insulin, then of course people will be quite keen not to go on it. It will be seen as a punishment. So if you're putting insulin as a punishment, then you can't criticize people for not or trying to avoid insulin all our times, because that's the approach. I seek to be more trust building, clear, empowerment, and collaborative. But I'm going to skip through those and get to an important point, which is this one, which is more relevant for Indian audiences. So last year or so, as ever, Banshi Saboo is everywhere in the whole India. I think I don't know how close he is in popularity to Mr. Narendra Modi himself, but he's everywhere. And Banshi was great in combining with us. He looked at this document and was very helpful in trying to create an Indian version, which we've done in two segments. The segment one is the type 1 diabetes segment, which has been done, and we have worked with an organization called Diabesties, which has been very helpful. So they have worked together and created this for us. It's there, it's online. As far as I know, it's on the Diabetes Care website as well. So please have a look. It's here are some examples. This is Jazz Sethi, who's part of Diabesties, one of the patients who's done it. And as you can see, this has been done. There's a Hindi version of it. There are other language versions of it coming out. It's been done from an Indian context. So I think the message that I can leave you with, there is a UK version, and quite understandably, people will say, well, actually, it's not applicable in a lot of settings in India. Well, you've got an Indian version as well. So please find your time if you to have a look at it. It's very short and sharp. You might find it very useful. That's the type 1. And for type 2, there's one being also done by a group of physicians in Mumbai. Dr. Tejal Lathia and a few of our colleagues are doing some focus groups, and there's some good work going on in it as well. So that's from the Indian context. Taking it further, during the times of COVID-19, we also had this, which was very useful, because one of the big problems with COVID-19 is the false information that goes on all around the world, and it spreads like wildfire. So this particular document was created with the help of Shashank and again of Diabesties, etc. That's there as well, and it targets about what language to use and what, to reassure your population is the main message. So the whole point being it's about how we interact with people. People will always remember a good physician in the way their behavior is, etc., and how they approach it. So I'll leave you with this quote, is that from George Bernard Shaw, which I believe in a lot. We see this all the time. We as physicians believe that we try our best and we have a good conversation with patients. If you then go out and ask a lot of your patients, there's very good evidence to say that a lot of people will turn around and say, well, probably didn't quite go as well as the doctor has believed. But either way. So the message really to leave is that is asking everybody is that there is no point in having the most modern medication or the best diet and etc., unless we can, for want of a better word, sell it better. And we can do that without scaring people in modern times, because you scare people, people move on and don't engage. And that's all I have to say on this topic. And as I said, there's an Indian version of it. Please find the time to have a look at it, which is an excellent piece of work done by Indian colleagues. Thank you.
Thank you, Partha. It's a very, very nice presentation, very fluent, very interesting. And with that, we end the session of these 3 lectures. We call everybody on the screen and for a question answer session. Purvi, would like to begin the first question?
Sure. So I think first of all, let's go with all lengthy answers and discussions because we have plenty of time, and let's maximize that to the benefit of the audience. So with that, I think all the 3 speakers did a fabulous job, and DESG and Divicon would be really proud of this symposium. The first question is for Dr. Shailaja from Dr. Ajita. Till what level of creatinine are you comfortable with prescribing ACE and ARBs?
Yes, it's a standard fear in a clinician's mind. There is no cutoff by all the guidelines. If you are using it for over proteinuria and protecting kidneys in a diabetic nephropathy, One can use ASARB. Only problem is the potassium. So we need to see other drugs which will not also increase potassium, and you need to monitor potassium. Otherwise, the investigators of the major ARB used in diabetic nephropathy trials say they will just go on if they have a good control on potassium,
Right.
I,
even with the high creatinine.
Ma'am, so I wanted to ask you one more question following that. Do you think with all these international guidelines, do you think there is a specific need for an Indian guideline and something that which is very relevant to the Indian subpopulation and something that we need to follow
Yeah,
as
there are Indian guidelines, and I showed there was a slide in that how it
yes,
gets compared with the ISH guidelines. I
yes.
think we need a bit of updating will be done this year, but I think our guidelines say the same thing that low dose cheap drugs combinations early, and we have the targets which are same as the most of the international guidelines. Still, our guidelines are not dividing according to cardiovascular risk, which ADA has done. But let's see what the update says.
So there is a need for some more granularity in these
I feel
guidelines.
Indian patients need because we are more young. As I said, there is more sympathetic activity, as which is seen in many studies, and so definitely we use a lot of beta blockers, which are almost till 2017-18 guidelines. They were there as a major part. Now we can't see them. Of course, we use atrial fibrillation, heart failure, ischemic heart disease. This is we all use selective beta blockers, but even as a routine, not as a fourth or fifth kind of a thing. So we do need Indian guidelines, and a good Indian kind of a data will be required.
Sure.
in fact, Shailaja, if you look at the ISH guidelines, one of the writer is Dr. Dorare Prabhakar, who's from
Yes,
India.
yes.
And it does cover some part of the Indian requirements. So I don't know whether we require a special guideline for us, but if you adopt any guidelines properly, because most of the guidelines are supposed to be misguidelines because people don't listen to them, they don't follow them, they just discuss in the lectures, but then comes to practice, I think what we should know is what is the adherence to this guideline by the physicians or a primary care provider to follow these guidelines to T and give that kind of a treatment to the patients. That is what important it is.
I completely agree with you, Dr. Neglur, that ISH actually has taken all the countries, and that was the main aim of ISH 2020 to bring everyone together, right from blood pressure checkups in the clinic and treating early. That's what it's required in India, I think.
Right. There's one more question for you, Shailaja.
Yes,
Talked about J-shaped curve,
yes,
and you said that the so far as the cardiovascular events are concerned, it is detrimental, but it was
yes.
beneficial for the brain,
Strokes,
both in the
yes,
network speed and the other city is short.
yes.
The question that is addressed to you is that is it because of the autoregulation that the brain
Brain
different from the
sustains.
heart because at the specific amount of mean arterial pressure, despite of change in the pressure, the flow is maintained. What the tissue wants is a flow, no matter what happens to the pressure. At the wide range of pressure, the flow is well maintained, so far as the brain is concerned. So is it the autoregulation that is defective in the heart compared to brain, or is it the brain autoregulation is far superior than that of heart? That's why this change in the pressure causes a difference in the flow. Ultimately, it jeopardizes the flow of the tissue.
Yes, the mean arterial pressure, as you said, and the perfusion, which is also true for the kidneys,
Mhm.
because they also
All
get
organs are autoregulated.
benefited with the autoregulation as same as the brain. So what you are saying is true, and I think that's why the brain benefits. But it's not only cardiovascular mortality; overall mortality also goes up if you push down systolic blood pressure below 120. And again, all the major trials are showing the same. So overall mortality is also slightly J-shaped, not only cardiovascular mortality.
That's the next question to Dr. Toti Florian. You talked about reversal of diabetes. There's a doctor from UK, Roy Taylor, who also speaks about the reversal of diabetes in patients of type 2 diabetes. And he talks about twin hit hypothesis. One, he says, is insulin resistance in the system, general insulin resistance and insulin resistance in the liver. Do you think that insulin resistant liver also has a role to play for the
Yes,
reversal of diabetes?
yes. Some of the slides that I have used for my presentations are coming directly from this lecture that he has done in 2012, I think, in the ADA Congress. And this is important because when we reduce the carbohydrates and we reduce in general the caloric intake of the person, some of these portions that we reduce is affecting positively to the liver directly. So helping the liver, we are helping the whole organism, and so we have a better control of diabetes, reducing gradually the number of treatments and also having other positive outcomes as it is for the blood pressure because they are very related with each other. So this is one of the ideas, and it was used in in the I don't remember now the name of the center in UK. What it was one of the first one using this kind of very low carbohydrate diet and with very good results, especially for people with a short duration of diabetes. Was the idea, and from that took the essence the direct study that I mentioned in my presentation.
There are a lot of studies from Japan who looked at low carb diet. And what was shown in them was as you start reducing the carbohydrate to say 60% or below than what they consume otherwise, there's evidence of ketosis in these people because fat being burnt in
Yes.
preference to carbohydrate.
Well,
Do you think it is detrimental or is
yes.
it's a welcome?
One of the ideas or the names for this diet is ketogenic nutrition therapy. So this is the idea, and this is showing that the diet is followed by the patient themselves. So it's quite what we accept with these kind of very low carbohydrate diets.
Right. So, just to take that point forward, I think intermittent fasting also has a lot of anecdotal evidence right now, and not very organized in randomized control trials. So, what is your comment on that? Because um from these studies, it's evident that if you're in the first 5 or 6 years of diabetes, it's still possible to reverse, even if you are on insulin, as you showed in your data as well. However, patients of long-standing diabetes who follow rigorous schedules of intermittent fasting are able to reverse diabetes quite successfully. And that's anecdotal evidence again. But what are your thoughts on that, Dr. Florian?
Well, the thoughts are that for every one of the patients there is still hope. It's true that if they have overweight or obesity, they have more possibility to reverse the diabetes. If there is a patient with a normal weight and with no fat liver disease, the results could not be very good. There are some diets using this intermittent fasting. Well, I'm not quite familiar with this idea, but in general, every diet that is restricting the calorie and especially the fat, especially the saturated fat, could have a better result. And we have seen with all the patients that when they lose weight, they have good, better metabolic control and less treatment, at least less insulin, let's say, in general, that they have before. So there is hope for every one of the patients that they want to lose weight and to have a healthier uh, eating habits, let's say, at the end.
Would any of the other panelists like to add to this? Sure.
Um, so from my point of view, so we are involved with the direct trial because of the national work we do, and we are trialing low calorie diets. We're also trialing sort of low carb diets. I think the initial feedback I can give you, just to echo our speakers' um, views is that I think it's going to boil down to tolerability and who can sustain whatever diet it is.
Hmm.
I think the main thing would be to put on the table a few options for the patients, whether it's a low carb, a low calorie, and I think the bigger question in an Indian setting will be the added how shall I put it, the added spice, so to speak, when you think of the cultural things that we have. You talk about the festival, you talk about, for example, how it's seen. You go to somebody, and I'll give you one personal example. I went back home, went to see my parents, then went to see my relatives. As you know, we've got millions of relatives. You have to go to everybody's house, and you have to eat sweets everywhere. And if you don't, it's actually seen as being insulting. So I think there's a lot of things that need to work. So it's difficult to sustain it. I think that will be key thing. And the tolerability comes with that, because those of, if you look at all the trials with low carbs, low calories, etc., there is no debate. It makes you lose weight. The problem is what happens after a few months, because it starts to even out, which is what the bariatric surgeons always talk about, because they say, look, we can give you longer benefit rather than the tapering off. So that's the debate, always goes on and on with that. So I think it will depend on, so I agree that it doesn't matter how, but if you lower your calories, but you're lowering X, Y, and Z, it will work. The question is whether you can sustain doing that, so there you go. I mean, I come from Bengal. So you try and do Durga Puja without any mishti or any shondesh, it's going to be pretty impossible, but there you go.
That's a very valid and very interesting point you bring about, because India, with its diverse regions and
Yeah.
food habits and the multiple festivals that are celebrated, and rightly so, and the almost 22, 23 official languages that
Yeah.
exist in India, I think that's really very important.
Yeah, I
So
mean,
what
as I said, even in the times of COVID, the thing that opened first in Bengal was the sweet shops, wasn't it?
Yeah.
exactly?
Yep.
And alcohol also.
And alcohol, of course.
Partha, I want to
Yes,
ask a
even
question to you. Yeah,
Sure,
yeah,
ma'am, please go ahead.
sure, sure.
even the type of bariatric surgery that also decides, because the
Yeah.
simple clamping and the thing, actually the weight comes back as well as the diabetes
Hmm.
within
True.
just few
Actually,
years,
when my
and then
laptop
the bypass surgeries do well. My question is, how many percent those patients who strictly do these low calorie restriction diet, what is the percentage of them they actually see some reversal, and what's your definition of reversal?
So, from our point of view, so if you look at the 2-year data now coming up, the dropout rates are starting to go up, as you would expect. So
Yes.
I think, if my memory isn't completely off on this, I think people who have sustained it at 2 years is now around about 40% mark, which has dropped down from
Okay.
the 1-year mark, as you would expect. What is reversal? And this is a hot topic of debate. Always people are going around. So what we tend to do is the maintenance of the HbA1c below the cutoff for diabetes. And I think so for us, the definition keeps stretching out. So if people are doing it at the 2-year mark, they've definitely, what we're saying, has reversed it or put into remission, whichever terminology we need to use. But generally speaking, 6 months is definitely used to begin with, from what I can see.
Okay.
Is it reversal or is
Thank
it
you.
delay?
So
Is
in
it
that
delay?
case, should we just stick with remission rather than reversal? That's
Yeah. So
somewhat
yeah,
stretching it.
these things always get caught up in controversy, don't they? Diet is the most controversial field, because it also sells books and TV programs. That's the problem. So,
Okay.
um, I, you know, I, reversal is something you would have thought that you can't change back, if that makes sense. And
Right.
all data would suggest that. I don't think we should give the message to the patient, you reverse your type 2 diabetes and it will never come back. That would be the wrong message to give.
Yes.
So I think remission has got that added bit to say, do you know what, if you don't keep at it, this will come back. And I think it's a bit like, we
Yes.
talked about alcohol. The same as alcohol. If we're trying to reverse, it's not to say to the patient, we give up alcohol for 6 months, you're cured. We're saying that it might still come back. And I think that's the same thing that should be
I
operational.
can say word delay diabetes, not reverse, delay. Delay is a better word. And
Right. Yeah, that's why personally I don't think it's a question of semantics, and both are not interchangeably used. It is actually remission, which may be of a
Yes.
longer duration in some versus others.
Yes. I think it's better because it gives the idea of awareness again to people with diabetes. It's like the food problems in some cases we don't say that you are recovered,
Mm,
you are in remission. So I think it gives the idea that it might come back again.
good. Yeah.
Right.
So I agree with Partha with that.
And just about this language thing, I had one thing with lot of digital medium now.
Mm,
I found the videos
mm,
which go beyond the language
Hmm.
mm.
is also a great tool for the patient education. And with the COVID, everyone has turned to the digital media quite a
Yep.
lot. And we can use videos which
Mm,
can go beyond the language and can be
mm.
useful for the community.
Absolutely. I mean,
Absolutely.
we have just had to, I mean, forced by the COVID and everything, we have just launched a full online self-management program for everybody with type 1, type 2 is coming out in July. Some of it is forced by COVID, but I think that's where the world is heading. I mean, who's got time now? That's the problem. So everybody wants to do everything quickly. Yeah, absolutely.
Since we are on COVID now, I want to ask you what is your experience during COVID episode? That was the diabetes well controlled and went off the control, or what is the percentage of people who remained well under control, and what are the percentage of people who got off the control, and why
During the
this
time of
happened?
COVID? Is it
Yeah,
during the
during
time
the
of
COVID lockdown, I mean, the lockdown still continues in India officially, though a lot of
officially?
people are seeing moving around in the street, but
Yeah.
officially still lockdown is on. So what happened to the control of diabetes during the COVID period?
So two or three things. It's very difficult to give you a national view on it because lots of places stopped doing HbA1c because they didn't want to see patients and have those blood results. So what we have seen is that people who have got access to a degrees of technology. So there are two groups of people. Group one is people who have got access to some form of technology which they can download and you can see. And because they've been at home, group one have really taken it upon themselves to lessen their activities. Sorry, the other way around, do some more activity going out, looking after the diet, dropping this and that, being more careful, and have done well, right? There's another group who have gone the other way, which is their exercise levels have completely dropped. They're eating more junk food at home. So I think it very much depends a lot on the personality of the person concerned and how much the lockdown has affected them. So we don't have a clear-cut picture, but there is actually some papers coming out, and two papers that I'm aware of. One is from France, and the other one is coming from Germany, where they have done not a huge number of patients, but they both say the same thing. And I think they're more self-motivated patients whose HbA1c seems to have improved rather than get worse. Now, that may be a reflection, as I said, of the personality of the individual concerned and the support they have around them. So I think that it's a mixed bag, and I think that's what you will find in Indian context as well.
Uh, the large number of patients
So,
were at control because they ate home food. They were all
Yeah, no, no,
together, the
I
family was
agree.
together, and they have participated everything in the activities at home. So what I saw, large number of patients were on the target, and
Mm,
each one of them were counseling, helping each other. The family as a whole, family as a unit worked together. So it worked as a sensation
yeah,
and got the best benefit to the patient. And patient also felt that somebody is monitoring him because
mm,
everybody's at home. There's nobody's allowed to go out. So it did
true.
really have a good impact on patients with diabetes. But as you said, the lack of activity, exercise was a little less, but I think the diet was well taken care of.
Yeah, true.
so in fact, in the last 3 months of practice during this COVID lockdown, uh, very roughly, I thought the socio-economic background of the patient also was a huge confounding
Huge.
factor in terms of the outcome over
Mm,
3 months.
mm,
And I thought that was very important also in terms of how scared they were of contracting COVID and
yeah.
how particular they were trying to be about uh, getting everything possible to control their diabetes with respect to diet and exercise also.
Yeah, no, I mean, I was doing a talk yesterday on COVID, and obviously I'm involved in the national COVID response. We were doing the talks and the data, but I've got a lot of respect and time for what India has done because I think, we can have a debate about the politics and the numbers and everything, but I think people forget the diversity of India,
Hmm.
and it's so difficult. It's not easy to just put a whole country in lockdown like you can afford to do in the UK. It's a very different planet altogether. So in spite of all that, I think people are doing the best they can. That's the way I look at it. I mean, India is not as straightforward as anything else. That's my view.
No, that's well appreciated. We all felt the same at many levels, that it was handled quite well. It could have been much worse.
Yeah, yeah, absolutely.
Dr. Shailaja, what was your experience during the last 3 months with respect to hypertension and blood pressure? I mean, and diabetes control. And did you have any particular tips that you gave to the
Yeah,
patients?
I think there is a question also in the chat box about what is the safest way to measure patients' blood pressure in daily diabetes OPD in COVID era. I remember the presentation from the Wuhan where they used all automatic blood pressure where data was transferred to one person sitting with four computers, then the data was transferred to the doctors, and that was a great paper which they said, which is impossible in our situations,
Hmm.
but still automated blood pressure machines are the call of the day. So we should have a good validated automatic blood pressure machines in the clinic. And also we can rely on home blood pressure measurements, which patients bring in because a lot of consultation is going on digitally. So we need to check which blood pressure machines patients are using, whether these are the correct ones so that it can be relied on the data. So the standard machines which we use, I think it's difficult unless you are using PPEs but the standard OPDs need to be dependent on these validated automated machines. So my experience in COVID era, like we were open right from 22nd March, both the clinics. We took almost 100 phone calls every day, answering every patient quietly. And then it was not done very professionally because we didn't charge. And but in last 1 month, the digital consultation is increased, accepted by patients, and it will remain now. It will be a
True.
part of our now practice. At least some patients will we can see through the digital medium. That is a change which will happen even post COVID.
Yeah, there's one more question, I think, just to Chandra Kare, that there are a lot of people who have visit-to-visit variability of blood pressure. That you see a patient today, say a week later, say 10 days, 2 weeks later again, and there's chances that the blood pressure, though the patient is taking the same medication, is following all the guidelines, doing exercises, restricting the salt, maintaining the body weight, but there is a fluctuation in blood pressure. It's called visit-to-visit fluctuation blood pressure. Does it have an impact on the long-term
Yes, so
outcomes, especially the cardiovascular, to the stroke
yes,
and the heart cardiovascular?
it
Yeah.
is known and shown in the many studies that blood pressure variability is an important aspect of blood pressure control. And patients who show these different kind of fluctuations in blood pressure at different visits, or maybe at home something and completely different blood pressure in the clinics, this blood pressure variability adds to the risk, to the events, as well as to the mortality. So it increases the disease burden. And here comes the more how you manage 24 hours ambulatory blood pressure measurements, give us some insight that which medicines can be used, the longer acting drugs, and whatever is possible. But overall, it is associated with slightly higher kind of event rates and the disease burden.
Good. Dr. Florian Totti, there's a question for you.
Yes,
Are you listening? There's a question.
yes.
Yeah.
I'm here.
There's a question for you that what are the molecular mechanisms for the reversal of diabetes? How do you explain it at the molecular level? Weight reduction, reduction of blood pressure, change in lipids. That's all right. That we see as not molecular. It comes to cellular level. What exactly changes occur in the reversing diabetes? Whether its insulin resistance goes down, or the beta cell function improves, or the incretin axis improves. What actually happens in these patients that you say that they have shown a reversal?
Well, as I have explained as we have discussed before, this is the idea that there is in general an increase in fat amount in the organism and especially in the liver. And there it is the, the better way to invest and to improve in general the metabolic control of diabetes because the liver is the factory of the organism and it is a very active part in improving the gluconeogenesis and decreasing the level of glucose, because at the end the diabetes is related directly to the level of glucose in the blood. So when we improve the fat in the liver, we improve in general the insulin sensitivity and the gluconeogenesis also. So that's why we have a better result. But in general, when we lose weight, we decrease the level of insulin resistance in general, and that's why we improve and we can reverse the type 2 diabetes. This is a simple way to say about the idea of reversal of type 2 diabetes. And it is done either by the correction on diet, or it is more rapid and more effective through the bariatric surgery. But personally, for me, I believe more in changes in diet and habits in general, because this is what we have for a healthier life than in bariatric surgery, because bariatric surgery in a way change the way from the external, not from the internal of the person.
So do you think the change in the
I am more
internal?
related to education, that's why probably.
Right, right, right. Very
So
good, very good.
there are a couple
Do
of
you, I mean, do you
questions.
think that there is more change in the islet milieu? For example, the redifferentiation of beta cells. Anything happens at that level when you talk of reversal? We
Well,
think that,
we have less apoptosis when we have an improvement on diabetes in general. So it also it's related to the level of beta cells, but it's more the pre-beta cell mechanism that helps in this way.
So
thank
there
you.
are a couple of questions more for you, Dr. Florian, and one of them is you did allude to the fact that lean diabetics may respond differently. Can you just elaborate on that? What, because most of the reversal is weight driven and more
Uh,
pronounced in patients
yes,
who.
it's in all the studies that are made, you may see that all are or mostly are obese or overweight patients. That's why probably there we have more possibility. But as I said at the end, through the to the conclusion, that even for a lean patient, if there is a strong fatty liver component, we can achieve some result. Well, in general, the studies are made to see the result, especially for bariatric surgery, are with obese people. So we don't have data about normal or lean patients. The only data that we have till now, there are some anecdotes that you have mentioned,
Hmm.
that even in some patients with long duration of diabetes, it was an example in New Zealand, I think, with more than 30 years of type 2 diabetes,
Hmm.
they changed it completely, his way of living, and has lost a lot of weight, changes the diet, and now it's without any medicaments. But anyway, they still need to continue with physical activity and diet. So for the lean patients, I cannot say anything more than what the studies just say. I am more interested to know if these kind of studies can be made in your countries, for example, or in countries neighbor to India, because in a lot of studies there has been seen that for lower BMI, people in these regions have a greater risk for diabetes in general, or if we change the diet, we can achieve or we can improve more diabetes. So I would be more intriguing to have some studies from your region. Probably they can answer what you are saying, because it is all related with fatty liver disease. So
Right, and there is some emerging data from one of our senior colleagues, Dr. Neeta Deshpande. And she was going to present it this year at ACE in the US, but we know that that meeting, obviously, everything has
yeah.
changed in the last 3 months. Dr. Shailaja, one last question for you. What are the systolic and diastolic BP targets that you recommend in GDM patients? That question is from Dr. Gauri Tamankar.
In pregnancy, the recent guidelines are saying 135 by 85 should be the below targets for not GDM, but actually diabetes and pregnancy. So, which includes the whole group. and that's the target. And usually they differ, but between the obstetricians and there's a two different school of thought, and the treatment planning is also slightly different. It depends on a lot of other factors, sonographies, and what's happening inside the uterus, and edema and hormonal changes. But the guidelines, ADA 2020, it's 135/85.
Right.
And my last
Thank
question,
you.
2 minutes for last question, Partha. I think for you, the last
Yes.
question. How do you convince your patients of type 2 diabetes to take insulin injections? How do you convince? What is your method or what language you use to convince patients of type 2
So
diabetes?
I think for me, the basic crux is to make sure that people are see it as part of their type 2 diabetes treatment, not as something separate, right? And I think we are fortunate in one way because in India, let's not forget, and when I was doing my medical degree in India, I remember the stigma associated with insulin, syringes and needles and public perception, etc. So one of the two things we have worked quite hard on is one is changing the way that we approach type 2 diabetes and making sure we see insulin as just a treatment. And I think GLP-1 analogs have helped a little bit with that because that's also an injection, but it's not insulin. That's number one. And number two is we make it very clear to a lot of celebrities and a lot of politicians and a lot of people to make it very public that insulin is not something to be scared or worried about or ashamed of. And that makes a big difference, you see. So to see a country which has got a prime minister who's very open about the fact that she uses insulin and she wasn't on a pump, she was on, MDI, that makes a big statement to people. So I think those two things are very important about changing public perception, one from the public's point of view and the other from the healthcare professionals' point of view. Those are the two things I would say.
Thank you. Thank you,
Sir,
Florian.
can I make one last comment which we have received?
Mhm.
So it's from Dr. Arvinda from Bangalore, and he says, Dr. Partha, language is a big factor in my multicultural city of Bangalore, and luckily we have softwares of different cultures. So
Fantastic.
I think that's a very valid and a very interesting aspect that he brought forth. So, do you believe in validation of these translations? And
100%. I would say that, so my work has been to get the concept of it into India because India is my motherland and everything. It's not copyrighted. I don't charge for it apart from a samosa when I go to your places. Bar that, it's all yours. You want to adapt it, you want to change it, please go ahead with it. I'll be very proud if it is in every single language. And I do know that the diabetes group was working, and Banshi will as ever have the details of that as to they're working with different groups. But please, if you feel you can convert it to a local version, I would be delighted. Just drop me an email and off we go. As straightforward as that.
fantastic.
No problem.
Thank you very much, Dr. Florian Totti, Shalita Kale, and Partha for a wonderful presentation and a good interaction. A lot of questions were there. That says that you generated a lot of interest among the people and a very well answered questions. And I thank Dr. Bansi and all his teams. Dr. Arvind, I can see him on the screen smiling. And thank you, sir. Dr. Mithun Bharti, I can see him. And thank you very much, everybody. And of course, Amit, thank you very much for everything that you did. Thank you.
Thank you.
Thank
Thank
you
Thank
you,
you.
very much for
everyone. It's
inviting
not
me.
often that we get
Bye.
such a wonderful academic treat. So, thank you, Dr. Bansi. Thank you, all of you.
Thank you.
Thank
Thank you
you.
very much.
Bye.
Thank
Bye.
you. Bye bye.
Bye.
Thank you. Bye.